Well, I'll be talking about the role of MRD, which is minimal residual disease, in the management of acute lymphoblastic leukemia of adult patients. And I will show how and why this test, MRD, is very important to perform in individual patients to refine the prognostic profile, and also to decide about final treatment, which normally is standard chemotherapy for the people that we define MRD negative, I'll explain it in a minute, and is empowered by allogeneic stem cell transplantations in those who are defined MRD positive. Yes, MRD is minimal residual disease, which means it's the disease itself, and it's measured in patients who achieve a complete remission, so who respond very well to the initial treatment, to initial chemotherapy, and are apparently without any sign of the disease in the blood, in the bone marrow, and are clinically free of any symptom. But we know that some leukemic cells may still harbor in the bone marrow of these complete remission patients. And there were highly sophisticated methods developed in the lab for measuring this residual disease. It's basically, it can be assessed by means of molecular biology or by means of multi-parameter flow cytometry. And it allows us to assess whether in a CR, in a complete remission patients, there is still one leukemic cell out of 10,000 of 100,000 normal marrow cells following the first steps of chemotherapy. And this is a very important prognostic information, because in patients who still harbor residual disease, there is a very high risk of subsequent relapse. We define these patients as high-risk patients. On the contrary, the patients in whom we don't measure any residual leukemic cell, we define them as standard risk patients. We are very happy because we know in advance that the relapse risk is much reduced, and we can continue, we can carry on with standard chemotherapy without any intensification and without any transplant procedure. So it's convenient, it's more convenient. No, it's not much different. The difference lies in the typology of the patients, because the older patients usually express additional risk features with more frequency than children. They are more adverse biological subsets of the disease, so we get an inferior MRD negativity rate following the initial chemotherapy. We have worse patients in general, so we have inferior results with MRD negativity, and we expect higher rates of MRD positivity. It's a disease more difficult to treat compared to children. So this is why it's worse, including MRD. Less positive results.